I thank CAHO for providing me this opportunity to chair this session. And to quickly introduce myself, my name is Mukta Arora. I'm the founder and CEO of Glio Health, a remote patient management company. We help hospitals and clinics provide therapeutic interventions to patients beyond their four walls by using our patent-filed platform, which is built on consortium of technologies from medical IoTs, cloud, analytics, adherence engines, medical communication engine, and AI ML. This session brings a potpourri of ideas and strategies on clinical data analytics, digital workforce, and tracking quality. And we are all aware that technology implementations are not complete without workforce quality as well as data analytics into the pie. Our first speaker is Dr. Dinesh Jain, who is the Vice President of Clinical Data Analytics at Max Healthcare, a leading healthcare provider in India. He brings deep healthcare expertise covering clinical, IT, and executive management in clinical information systems and data analytics. Clinical analytics is a field that makes use of real-time medical data to generate insights and take decisions. Let's hear from Dr. Dinesh how implementation of clinical analytics can reduce medication errors, improve population health, increase revenue, and save costs for the organizations. Over to you, Dr. Dinesh.
Thank you, Ms. Mukta, for a warm welcome. And also, I would like to thank the organizers for bringing us all together on this platform today. So today, I've been invited to share with you the journey of clinical data analytics at Max Healthcare. As you already would know that Max Healthcare is a network of 17 facilities, mostly predominantly based out of north and west of India. We have been running this department for the last 6-7 years, and it has been a journey where we have started through small projects, and then we have gradually built up on top of that to going to more complex projects. Today, I'll be talking in general about our journey, as well as I'll take this opportunity to present one case study of one of the recent projects that we did on the outcome measures. So the first question that comes when we talk about data analytics is, what can it do for you? I think in short, the idea behind using clinical data analytics in a healthcare environment is that it can leverage the power of data and technology for excellence and clinical research. That in a nutshell, it gives a lot of opportunity for the healthcare organizations to improve their processes and their outcomes. Also, it allows us to develop and build predictive models, which can help us to improve the patient care and the patient outcomes. Instantly, it also supports the development of advanced capabilities in the information systems for clinical use. For example, clinical decision support system, prediction scoring, clinical outcome measures, so on and so forth. And these are all, I would say, incidental outcomes of the application of clinical data analytics. I will share a little more about these when I go to the later part of our presentation. So let me first start with a case study where we talk about the clinical outcome measures project. Increasingly, we see that the accreditation organizations are looking for standardized processes to evaluate the quality and safety of the patient care provided by each medical staff member. And that is implemented through the monitoring of objective measures, which is done regularly at defined intervals. And that allows us to identify areas for clinical improvement. So in nutshell, what it all does is that it improves and helps with the adoption of quality matrices, as well as help us identify the areas or gap areas where we are weak and we need to improve. To give you a snapshot, let me share earlier status of what we were doing initially, and I believe most of the hospitals have been doing that. When we look at the quality and safety parameters, you see a handful of parameters, and most of these parameters are manually run as well as have a paper trail to back them up. And this is a very, very people-intensive process. And there are always issues about the quality of data as well as the auditing process. However, when we have completed our project, this is the current state where we see the entire state, the array of parameters that we are using for quality and safety that has undergone a transformation. We have a huge number of parameters that we are tracking, and all of them have a system backup where there is no manual intervention in terms of data collection, analysis, and auditing. And the entire trail of data is maintained on the system. So that allows a transformational change within the organization. So let me go through the process, how we went through this entire project. The objective outcome indicators were the first ones which we had to identify. And then these were standardized across the departments. The system was built which could automate the data mining and transformation process. And ultimately, it has to lead to a transparent data access and availability. Along with the whole process, there were benchmarks, which were the best-in-class international or regional benchmarks, which were adopted and used as comparative points where we could look at each parameter value against these benchmarks. And then we have a regular monthly or quarterly clinical outcome dashboards, and the scope of this entire system is throughout the organization. The methodology that was followed in brief is we started with the selection of clinical measures. To do this, we worked with the clinical department heads to identify the relevant and significant clinical outcome parameters for their departments. Once these were identified, the benchmarks were set and the references were picked up, followed by the development of in-house software, which could automatically extract the data from the electronic medical record system. This resulted in a huge reduction in the manual effort that was involved earlier and a reduction in the error, which was typically built into this process. Now, this was followed by a huge exercise where data analysis and validation was conducted to verify the system and the algorithms that were running within these systems. And data can be sliced and filtered at multiple levels across this. And the results have been heartwarming. We find that approximately 78% of the outcome measures, we are at or above the best-in-class levels, which we have identified as the benchmarks. To give you a sense of how this looks, earlier we were tracking a total of a very limited set of outcome parameters, a total of 18 clinical outcome parameters, which were being tracked. And now that has grown up to more than 50, close to 60 parameters that we are tracking now. And these are all at the departmental and the individual clinician levels also. Earlier, it was a manual process of data collection, and now it's a real time live dashboard, which is available to all the end users. There were high chances of errors, and the chances of catching those errors were very, very time consuming. And now it's almost a zero error process. Long man hours were consumed in running the system earlier, and now there is almost no time apart from the time and effort that we have expended in developing the system. It was difficult earlier to audit and validate. Now the entire data set which goes into this analysis is there at the touch of a button, available for every end user to check and validate. And this innovation has been developed in-house and has set helped us to create a role model within the organization where the information systems and the processes help us to improve our clinical processes. This is a snapshot of some of the indicators that we have been using. So here, as you can see, that we have used at least 2 indicators for each clinical department. For internal medicine, you can see that there are 3 indicators. The first one, which is ICU transfer rate. What it does, it measures the transfer rate of patients admitted to non-critical areas and then subsequently getting transferred to a critical department. So that parameter is tracked, and the standard benchmark, which we have picked up from the international published data, is set as at 3.7%. So that gives us allows us a way to track as well as to benchmark ourselves against these measures, which have been developed in the best of class hospitals worldwide. There are other measures like 30-day all-cause readmission rates in pneumonia and UTI, again for internal medicine. For the Department of Critical Care, you can see that we have one parameter, important parameter, which is 14-day critical care return rate. And you can see that many hospitals do track this. But here, what we are doing separately is that we are doing it as a standardized process across all the hospitals, across all the critical care departments without any manual intervention. So, and this is how the dashboard looks. This gives us a real-time look into the each parameter value. The ratios are the numbers, numerator and denominator, along with the ratios are there. Now, quickly, I'll go through the timeline and the journey that this department has traversed over the years. And this is just to show how the complexity has been increasing over the years. We started very small. We started with a very small program where we developed a VT prophylaxis program. It was a clinical decision support system that we developed on top of the electronic medical record system. And we used it to identify the moderate and severe risk patients for venous thromboembolism, and for those patients, we try to ensure that each of these patients were assessed, and proper prophylactic program was instituted for these patients. Then gradually over the years, we went up the complexity scale. We developed a healthcare acquired infection surveillance program, which looked at CLABSI, COTI, VAP, and SSI within the hospitals. And this program is a very interesting program that we developed. Initially, when we started, we realized that the criteria which the CDC has defined for each of these HAIs is very complex. So we started small, and we thought we'll pick up what the higher suspicion cases are within the entire hospital population, and then put it through a manual process of infection control nurses and infection control doctors running that process. This system feeds the surveillance system, feeds the data into this team, and they then look at each particular identified patient to see if they fit into the criteria, and then they do a root cause analysis. Also, we then started looking at the antibiotic consumption in DDDs. This gradually enlarged into our antimicrobial stewardship program across the hospitals, and we also started tracking a drug resistance index. Now, drug resistance index is a composite index which looks at 2 different parameters. One is the antimicrobial resistance, which in the population of the microbes, and also looks at the consumption of the different antibiotics which are used for this population of hospital patients. So this gives us again a very good snapshot in terms of how this is progressing over the years. We did our first predictive analytics project where we looked at acute myocardial infarction 30-day readmission risk model. and we developed it and looked at it for the population of patients coming to our hospital for acute myocardial infarction, then subsequently getting treated and discharged. Similarly, we looked at worked on multiple projects over the years. Other interesting predictive model we developed was predicting the length of stay of dengue patients, and we are as we are have a thunderstorm brewing through Delhi, where the prophecy is that prediction is that the number of dengue cases are going to rise in Delhi now. So that is something which we are looking through this predictive model. We have done more studies, predictive models again on IP volume predictions, dengue patients. Again, we did another predictive model, and most of these we have also published in peer-reviewed medical journals. Clinical outcome ages, of course, is one of the latest projects that we did, and the idea, I think, the behind showing you and taking you through this journey was that as we have progressed over the years, as we have matured as an organization in terms of designing the systems, implementing them, and then transforming our workforces in terms of adopting the change process, that has been a great learning. And over the years, we have been doing that. And as we have scaled on our confidence, we have been adopting more and more complex projects now. So with that, I think that's the message I would like to share with the audience here. And with that, I end the presentation. Thank you so much.
Thank you, Dr. Dinesh, for sharing with us an impressive journey towards building so many models that are improving excellence and creating fascinating clinical research. This indeed is a great learning for other organizations to follow these footsteps. And I'm sure going forward, clinical analytics is going to be a big subject in almost every organization that we look towards.